Yay.
So like I mentioned, this will be quite the undertaking to discuss all of psychopharmacology in the matter of 30 to 40 minutes, but it will be a very high level overview just so that we can get familiar about some of these systems that are involved, some of the commonly used medications, and that way, once you do see these in daily practice, you are more aware of them. So some of the goals of the discussion will be, to really describe some of the principles of medication management that we use. So we always lean towards behavioral and environmental interventions first, disease focused before symptom focused. And especially in our elderly population, you want to start low, go slow, and minimize polypharmacy. So if we can, really using the science of what receptors we're trying to target or what brain networks, if we can choose an optimal medication versus two or three different medications and exposing the patient to side effects, that's where the art of psychopharmacology really comes into play. So, and while we're prescribing these medications, we want to define the goals of care really in an explicit manner. So that way, the patient knows I'm taking this medication to help for sleep. I'm taking this medication to help for anxiety. I'm taking this medication to help for cognition. Because often what we find is when a patient will present back for follow-up, because they were unaware of what medication was doing what, now they've discontinued one medication and experiencing worsening of their mood, anxiety, insomnia. So really defining it in an explicit manner what the medications are supposed to do to both the patient and family member can be very helpful. So we want to identify key targets with those medications and establish these unambiguous expectations and clear priorities. So we'll talk a little bit about some of the targets and pathways. So we'll talk about these systems, the cholinergic system, dopaminergic system, serotonergic, noradrenergic, GABA, glutamate, histaminergic, melatonin, and orexin. These are all systems within the brain that we try to target with medications. And I have my frustrations about the imprecise nature of a lot of our medications, but at the same time, this is the best we have currently. Hopefully we'll do better in the future with, transcranial magnetic stimulation and DBS and things like that. But right now, these are the tools that we have available to us. So, and then we'll talk about some of the pharmaceutical classes. So the anxiolytics, stimulants, sedatives, mood stabilizers, antipsychotics, antidepressants, cholinesterase inhibitors, and anti-amyloid therapies. A pearl that I like to use, especially for, patients and families, many patients will hear antipsychotic and just have a sort of that stigma against taking a medication that's described as an antipsychotic. So I use the term dopamine modulator. So that way it doesn't really have that stigma attached. And then lastly, just some very brief clinical pearls that we can discuss about individual medications. So like we talked about, we want to define the goals of treatment. Even with excellent pharmacotherapy, relapses, recurrences are often inevitable. So in most of my patients, it takes 2 to 3 trials to find a good medication for, their mood, their anxiety, their behavior, their cognition. So don't be frustrated that the first one you pick might not have been the best choice.
Dr.
Now,
Kamal, can I jump in for a second?
yeah.
Are you advancing your slides?
Oh, yeah. Is it not?
Yeah, it's not showing. We're just seeing goals of discussion still.
Oh, okay.
There we
Let,
see that now. Now we're on clinical pearls. Now we're on
okay.
defining goals of treatment. Perfect. Okay, now we're caught
Okay.
up.
All right. I see. Okay. So, we want to explicitly define goals of care to manage those unrealistic expectations and really define the target. What medication are we using for which symptom? And not only symptoms, are we are there goals in mind that we're keeping with the initiation of these medications? So are we trying to restore disrupted sleep? Are we trying to avoid hospitalization? Are we maintaining social occupational functionality? Are we maintaining independent living? Are we wanting to minimize polypharmacy? So many times we'll receive a patient with a list of 8 to 10 neuropsychiatric medications with multiple interactions. Now our job is to really see what's working, what's not, and decrease the risk of cumulative burden of side effects. And one commonly overlooked is reduction of pain. Many of our antidepressants can be helpful for neuropathic osteoarthritic pain. So why not pick a medication that can be helpful for both? And then lastly, a target that often gets n- under what not enough attention is emotional wellness. These patients are all already going through a decline in their functionality, a decline in their cognitive capacities. So allowing them to enjoy their day-to-day functioning, enjoy their hobbies, and really have the motivation to participate is so crucial in their wellness because you'll find if their emotional stability is not there, their compliance and adherence to their blood pressure medication, to their cholesterol medication, to lecanemab is just not going to be there. So you have to really focus on their emotional well-being. And then lastly, slowing the progression of the disease. Now we finally have treatments that can actually target the disease process itself. So when it comes to the different stages, there are optimal times to start the cognitive therapies, optimal times to start the neuropsychiatric. And as you can see, usually with the cognition, earlier is better. But with some of the neuropsychiatric symptoms, these often manifest more towards the mild and moderate stages. And many times this can be even more challenging to manage than the cognitive decline because a patient may not remember the date, but once they start to get aggressive or agitated, assaultive, now it becomes a real problem. And that's when family members will consider, transition into a nursing facility. So we want to make sure that we preemptively address those because in earlier stages, it can be managed with more benign medications, whereas later stages, you'll see a lot more medications that have stronger side effects. And then we want to make sure we're addressing sleep, motor, autonomic functions, and then the disease modifying pharmacotherapies. We'll speak about lecanemab and donanemab towards the end, but again, we know the earlier the better. So we're trying to intervene at the MCI stage now so that we can really decrease that amyloid burden. And then getting the patient involved in clinical trials and research. Oftentimes, just that frequency of follow-up in our clinics is not there. So having someone do serial cognitive testing every 2 weeks can be helpful. And also, many of these patients have limited social interaction, so it can provide benefits even beyond just the research trial. Uh, is my, oh yeah, so we'll start by discussing some of the some of the pathways. So if you see the image on the left, we have the cholinergic pathways. Then we also have dopamine, serotonin, norepinephrine. So all of these neurotransmitters are really synthesized in the midbrain. And then they travel along these networks to facilitate cognition, mood, encoding, storage, retrieval of memories. And we want to make sure we're targeting the appropriate neurotransmitter. And that's where knowing what medication has the appropriate receptor profile can be very effective in optimizing that medication regimen. So we do have cholinesterase inhibitors. So acetylcholine is degraded by acetylcholinesterase. So if we inhibit the enzyme that breaks down acetylcholine, now acetylcholine can remain around longer in the synapse. So it can give that cognitive boost. So it can give a modest boost in cognitive performance in AD, Lewy body dementia, Parkinson's disease, and vascular dementia. but it doesn't necessarily affect the overall long-term trajectory. It can decrease sort of placement into nursing home, but it's not disease modifying as lecanemab can be. But it can also be effective for non-cognitive symptoms. So oftentimes we'll see irritability that presents just in the context of AD in the milder stages. You can try treating with donepezil for both, like we talked about, minimizing that polypharmacy. Side effects to look out for with the donepezil and acetylcholinesterase inhibitors is, the nausea, loose stools. What acetylcholine does in the gut is it stimulates digestion. So now it could be a benefit if the patient is going through constipation, but if not, it can cause diarrhea. And then REM sleep is associated with acetylcholine as well. So now patients will have more time spent in REM. So they can often describe vivid dreams. If it's non-disabling, the patient is not bothered by it, it's okay. You don't have to discontinue just due to vivid dreams, but sometimes they can actually turn into nightmares. So in that case, what we can recommend is taking the medication in the morning. And then lastly, look out for bradycardia because it can slow down heart rate. And so acetylcholine is very important in responsiveness to cellular stimuli. So in set shifting, maintaining goal-directed focus. So you can see a boost in cognitive scoring when you bring a patient back, especially in the first few months. One thing we want to avoid is antagonism of acetylcholine. So often patients will come on, oxybutynin for urge incontinence, which is a very commonly used medication for urinary incontinence. So think about we're wanting everything to really boost acetylcholine. The last thing we want to do is antagonize it. So avoiding these type of medications, benztropine, diphenhydramine, which is Benadryl, oxybutynin, even some of the tricyclic antidepressants that we'll talk about a little bit later, because these are all going in the wrong direction. So, we know that donepezil improves cognition in AD. It does delay the functional impairment and it delays the stage advancement. It can improve behavior. We know it's most effective in AD, but it can also be effective in vascular cognitive impairment, CADASIL, TBI, MCI due to AD, and even normal aging. So supplementing acetylcholine can be effective in the diet of foods. Eggs actually have the highest amount of acetylcholine, so I always recommend my patients to have, one or two eggs in the morning, in addition to taking the donepezil. But again, like we talked about, it doesn't target the disease process itself, and the benefits are temporary. I would use it in caution with frontotemporal lobar degeneration. In that disease, it can actually worsen behavior and cognition. So that's the one condition that I would not recommend use of donepezil. So now let's talk a little bit about the dopaminergic system. So the two receptors that we commonly target when it comes to dopamine is D2 and D3. So agonism can actually help with memory, attention, and focus. So that's why many of the medications we use to target ADHD facilitate dopamine release. But many of the antipsychotics that can be used in behavioral agitation in Alzheimer's disease antagonize dopamine. So now really the field has shifted away from using especially the older antipsychotics like haloperidol or even the second generation antipsychotics like Risperdal. They're more second or third line medications because if you think about we want to increase acetylcholine for memory, we want to increase dopamine for motivation and attention, executive functioning. So the last thing we want is really to deplete these neurotransmitters. So if we can refrain from antagonizing dopamine and using more medications like SSRIs, mood stabilizers, that's how you can really balance behavioral stability and optimum cognition. So because antagonism of dopamine not only can dampen cognition, it can also produce Parkinsonism, hyperprolactinemia. So there's a variety of different side effects that can be produced. So there's, we'll talk about these a little bit later, but the there's first generation antipsychotics, second generation antipsychotics, and most recently there's third generation antipsychotics. The benefit of third generation antipsychotics is they don't completely antagonize dopamine. So they're described as partial agonists. So they basically elicit almost a 50% response at the receptor. So that way, if dopamine is too high, like as if in Lewy body dementia, we can see psychosis and hallucinations, we can lower dopamine in those regions, but in regions that are associated with apathy, like, anterior cingulate, we can actually raise dopamine. So it more keeps everything in equilibrium. So when it does come to use of antipsychotics or dopamine modulators, I prefer to use this third generation. And a mnemonic I like to remember for the third generation antipsychotics is ABC. So aripiprazole, brexpiprazole, and cariprazine. Brexpiprazole actually did receive recent FDA approval for agitation in AD, but at the same time, it can be expensive to get from the pharmacy. So because aripiprazole has a generic, I think there wasn't as much funding for research. And I found aripiprazole to be just as effective, but technically, the approval is for brexpiprazole, but they have a very similar mechanism. But if your patient is having difficulty obtaining this due to funding, you can go with the aripiprazole that has a generic available. So, and the benefit to these third generations is they can also be helpful for depression versus, the first generation and second generation older antipsychotics that can worsen. They also have a low risk of QTC prolongation and weight gain. So now we can talk about the serotonergic system. So this very commonly we use to target affect and anxiety. So the receptors that we like to stimulate, one is 5-HT1A and the second is 5-HT2A. So the 5-HT1A, I like to remember, is very important for anxiety. So this is where medications like Buspar or Buspirone can be selective for anxiety, whereas some of the other SSRIs don't have as strong of an agonism on 5-HT1A. The 5-HT2A can be involved in attention and working memory, and that's where we do have some evidence of improvement of cognition, especially for patients with comorbid depression with SSRI use. So that's why I would say if you have to go with one medication in the neurodegenerative diseases, I would pick an SSRI just for safety profile and pro-cognitive effects. So among the SSRIs, the ones that we commonly use are escitalopram, also known as Lexapro, citalopram, Celexa, sertraline, or Zoloft. So citalopram is the most commonly used because of a study that came out in the early 2000s called the CITAD study. There was a follow-up study, the SCITAD study, that was published in 2019, but because the initial study was just so much more popular and many people did not look into the follow-up study, a lot of providers still prescribe citalopram. It's not to say that this is a bad medication, but one of the main reasons why escitalopram was developed was citalopram has the risk of QTC prolongation. And in the elderly, that's a lot higher of a risk. So escitalopram, the ES stands for S-enantiomer. So it's basically the active component. So you can take half the dosing of citalopram. So if a patient is on 20 milligrams of citalopram, they only need 10 milligrams of escitalopram. So it's basically the active component, and this active component doesn't have that same risk of QTC prolongation. So if you're going to start someone on SSRI, I would definitely pick the escitalopram just for safety profile. But watch out for headache, again, some GI symptoms. Sleep disturbances can be present, so I like to prescribe this in the morning. It can cause hypersomnia and dream enactment. And then in the elderly population, there's something called syndrome of inappropriate antidiuretic hormone secretion. So this is where their sodium levels can get too low. In my middle-aged population, I don't see it that commonly, but in the elderly population, I have had a few patients actually develop syncope and actually hit their head because their sodium is 115 or 110. So be careful. Once you do start the SSRI after a month or 6 weeks, order a metabolic profile so you can make sure the sodium is doing okay. The one caveat is in rare cases, it can exacerbate apathy, so that diminished motivation. So make sure you screen for this at follow-ups. And then, like we talked about, it's preferable to antipsychotics for non-emergent treatment of agitation. But in this, you want to be cautious in Lewy body dementia. So, like we talked about caution with donepezil and FTD, we want to be careful in Lewy body dementia with the SSRIs. There are some context-specific considerations. So if you have a patient that has both depression and low energy, very diminished motivation, you want to pick more of an activating antidepressant. So that's where something like a bupropion, which works on norepinephrine and dopamine, or a SNRI. So in addition to the serotonin, which can be helpful for mood and anxiety, now they're getting that norepinephrine. Now they're getting that adrenergic stimulation. So it's helping with that energy. And the norepinephrine can also be helpful because when patients experience neuropathic pain due to diabetes or even compression injury, now that norepinephrine actually drives neuronal regeneration. So that's why these SNRIs are actually FDA approved for fibromyalgia and neuropathic pain. So they can have some additional benefit even for migraines. So SNRIs specifically, I would pick duloxetine can be very beneficial in the elderly geriatric population because they usually do have some degree of that neuropathic pain. If they have poor sleep and appetite, a great medication to use is mirtazapine. And then if they have the anxiety, remember we talked about that 5-HT1A, the buspirone. We'll talk about gabapentin, which is anti-seizure medication, but can also be helpful for anxiety. And then trazodone, although traditionally understood to be used for insomnia, can also be used as needed for an anti-anxiety agent. So now let's talk a little bit about the noradrenergic system. So within the noradrenergic system, you have alpha 1 agonists, alpha 2 agonists, and non-selective beta blockers. I would say the one to really know out of these is the non-selective beta blockers because most of our patients at this age have some degree of hypertension. So if they're on a different type of antihypertensive medication, switching them to something like propranolol can really be effective for reducing anxiety, reducing tremor, and even helpful for migraine. So propranolol actually, Robert Downey Jr. recently came out and disclosed that he uses it before his Oscar speeches. So what it does is it's very helpful for the peripheral anxiety response when you get your heart beating really fast, you find it difficult to breathe, your blood pressure elevates, you get the butterflies in your stomach. So the propranolol can be very effective and it can reduce that peripheral anxiety and it can avoid really requiring the benzodiazepines, which we know can dampen cognition. So it can be used on a as needed basis when the patient is feeling anxious. Many of my patients with word finding difficulty or, even cognitive challenges, when they go out to a restaurant, they can't remember names of distant relatives. They can't find the right word to say. So these type of environments can be particularly anxiety inducing. So giving them something to help during those challenging situations can be very effective. So now we can talk about the GABAergic and histinergic systems. So GABA, we know, is the main inhibitory neurotransmitter in the brain. So whereas the previous serotonin, dopamine, norepinephrine, these are all excitatory. These increase activity in the brain. GABA is the main inhibitory neurotransmitter. So that's where if we want to slow things down, especially if there's anxiety, racing thoughts, too much hyperactivity, even tremor or seizure activity, we want to increase GABA. So it basically works like a circuit breaker. And then we also have the histaminergic system. So we'll talk about orexin as well, but histamine and orexin basically promote alertness. So that's how antihistamines like Benadryl or anti-orexin agents can actually facilitate sleep. So the two ways we really target sleep is either at making the patient feel more tired or more sleepy. So we have medications like melatonin, Seroquel, trazodone, or the other way to approach this is let's make them less awake. So that's where histamine antagonism and orexin antagonism comes into play. So these two are associated with alertness or being awake. So we antagonize these. So now the patient is basically less awake and more of a state ready to fall asleep. But like we mentioned, the Benadryl can also cause cognitive dulling, weight gain. It can be effective for allergies, but not the preferred medication we would really want for helping with sleep. Gabapentin, pregabalin, like we talked about, very helpful for anxiety, neuropathic pain, migraine, epilepsy. Our patients with AD are at higher risk of seizure disorder, so we want to be careful about that. And then melatonin agonists are another safe, so either over-the-counter melatonin or Ramelteon or antagonists of this orexin, which basically maintains alertness. And now we can talk about stimulants. So stimulants mainly target norepinephrine and dopamine. And we do have multiple studies that show they improve apathy in AD with methylphenidate, which is Ritalin 20 milligrams daily. You do want to watch for worsening irritability, anxiety, insomnia, decreased appetite. There are non-stimulant medications that can be used, like atomoxetine, guanfacine, atypical antidepressants, but these are usually second line because they take a few weeks for them to be effective. And even when they do become effective, they're never as effective as the stimulants. So just watch out for blood pressure. They can elevate blood pressure and heart rate. But apart from that, generally very well tolerated. Now we can talk about anxiolytics. So we spoke about buspirone with the 5-HT1A. We spoke about gabapentin, pregabalin. Another as-needed medication we'll commonly use is hydroxyzine, which is a little bit similar to diphenhydramine, but it doesn't have as much of the cognitive dulling effects. And then the non-selective beta blockers, mirtazapine, SSRIs, and SNRIs. I would say these are really the desired medications. If you have to, in some cases, we will use benzodiazepines, but you really only want to use these for short-term management. So if it's insomnia, seizures, akathisia, REM sleep behavior disorder, which is basically acting out of dreams, that's where you can use a short-term course while the SSRI is becoming effective. But really try to avoid long-term use because the longer you use them, the more tolerant they become, and the risks of respiratory depression, dependence, falls can be very severe. Like we talked about for insomnia, you can use melatonin. The two medications that I like to use most commonly for insomnia, one is trazodone, and the second is the orexin antagonist. There are, medications like Ambien, but there's similar risks when it comes to the benzodiazepines. So with sleepwalking, the cognitive sedation. So generally, the two to use more safely, and that can improve sleep architecture, are this trazodone and orexin antagonists. So among this anti-seizure medications, like we spoke about in AD, they are at higher risk for seizures. So lamotrigine is a medication I do like to use very commonly because it's very well tolerated, not a lot of risk for weight gain. Topiramate you will see used for epilepsy, but this is one I actually try to reach out to the epileptologist and say, can we get off this medication? Because now the likelihood of cognitive dulling will just be very high. So gabapentin, pregabalin, okay to use. Carbamazepine, I would say second line medication, but of these, the one that I like to use most is gabapentin. And now we have the dopamine modulators. So like we spoke about, we have the older haloperidol, high potency D2 blockers, but we don't want to dampen cognition. And there is a long-term risk of a condition called tardive dyskinesia, which basically they develop stereotypic oral movements. So we really want to avoid the first generation and second generation antipsychotics as possible. But if we can, that third generation, which is the ABCs, uh, aripiprazole, brexpiprazole, and cariprazine, these are the ones that we could use second or third line for that agitation in AD. So antidepressants, there are a lot of classes. I would say we don't use the tricyclics as much anymore. The mirtazapine we do commonly use. Trazodone can have some antidepressant activity. The MAOIs, uh, very effective for patients with PD. So if you have a dopamine deficit, it makes sense to select something with dopaminergic activity. And then the SSRIs, SNRIs that we talked about, and then Wellbutrin, I like because it's a lot faster acting. So it can work in 3 to 5 days. So you don't have to wait for the SSRIs, like the 3 to 4 weeks. And even can be effective for weight loss. The one thing I would be aware of with bupropion is at higher doses, greater than 450 milligrams, there can be a seizure risk. So if your patient does have epilepsy, it might not be the best choice. So lastly, let's talk about anti-amyloid therapies, which are all the buzz now. So finally, after working at this for the last 20 to 30 years, we have something that can really be disease modifying. So as behavioral neurologists, we're very excited about these therapies, but at the same time, we recognize the results are modest. So lecanemab did meet the primary and secondary endpoints in the Clarity study. Roughly, it was about a 25% reduction in the CDR sum of boxes. So it was a clinically meaningful outcome, and hopefully this will sort of stimulate and invigorate the industry to produce more disease-modifying therapies. We're already seeing donanemab was approved just this July, and more are in the pipeline. So I think overall, we're finally making some progress, which is something to be excited about. But at the same time, there are risks involved. So whereas donepezil is an oral tablet, pretty benign when it comes to side effects, lecanemab, there's risk of bleeding and swelling in the brain, and you do have to have an open discussion with your patients about this. In the Clarity study, approximately 14% of patients were found to have some level of what we would describe as amyloid-related imaging abnormalities. So area E or H, so either edema or hemorrhage. So only 1% actually had severe consequences. So, but at the same time, you also have to consider the change to the patient's lifestyle. Now they're going to come in, receive the IV infusion for roughly 2 to 3 hours, get serial MRIs every 1 to 2 months, and even the anxiety of knowing potentially I could be having a bleed every time they have a headache can be disabling or, really negative towards their quality of life. So having an open discussion with the patient about the risks, about the benefits, we will screen them for their ApoE status, which basically determines their risk of bleed. So if they are found to be homozygous for E4, their risk of bleed increases significantly. and they would actually be determined not to be eligible. So if you can see, one of the eligibility criteria here is the amyloid PET scan that we perform on our patients. So it's very hard. We have an algorithm that really interprets these scans, but you can see on the margin of the brain, the tracer will actually bind all of the white matter, which is basically the inner wiring of the brain, but the outer portion should not be bright. So if you can see on the right, the positive scan, yes, you have the white matter is lighting up bright, but also the outer cortex and the gray matter is also being shown to be positive, and we can also see it in the scan here. So once they have that positive amyloid PET and they're not E4 or E4, you can refer them for lecanemab, but having that open discussion about the 18 months of treatment, not being able to travel, and the change in lifestyle. But it's a risk and benefit analysis, and it's a personal decision for patients to make with their family members. And that is the last slide. So I know I went over time, but happy to field any questions, any clarification, anything I can be helpful with. And I would say, Amy, feel free to rotate my email if I can be helpful in any ways about clarifications on some of these points. If you have a challenging patient to discuss, more than happy. I've fielded many questions to my neuropsychology colleagues, so happy to return the favor.
Thank you so much. That was really, really amazing. I have a few
15 minutes. Yeah, we have 15 minutes. Yeah.
Yeah.
Great.
That was actually perfect timing. I couldn't have done it better myself. I have a few questions, but I wanted to open it up to the rest of the group and see if anyone has any questions, comments, reflections, anything that they have noticed with their patients and these medications. Take that as a no.
Brooks.
I'll go. Yeah, if that's okay.
Oh, yeah.
Thank you. Thank you. I appreciate it. I just, Dr. Kamal, I just wanted to thank you. I mean, I thought it was a really excellent presentation. I appreciated very much that you gave us your own perspective on things versus just, stating the facts sort of, and added that clinical context for us. I'm right now, I'm doing my internship in a psychiatric institute, and I was wondering sort of what your thoughts were on applying what you know to neuropsychiatry. And one of the things that we focus on here, especially with neuropsychological evaluations, is trying to disseminate between things like psychosis and MDD with psychotic features. That's been a big one recently. And sort of how you feel that pharmacotherapy, at least, could help distinguish between those two things, sort of maybe prescribing different medications and seeing what works, what doesn't work, using like previous trials, or whether, and then also for the neuropsychologists here, where you feel that neuropsychology would work collaboratively with neuropsychiatry to, I guess, for clarification of diagnosis.
Yeah, and thanks for the excellent question, Brooks. And I would say, so this is a plug for CBMM, but it's uniquely organized in the sense that they will have one fellow that's psychiatrically trained and one fellow that's neurologically trained. And then they bring us together and we sort of learn from each other. So I happen to be a fellow that was psychiatrically trained. And something that became rapidly evident during my training was the limitations of our medications. So just to give you an idea, the effect size of SSRIs is roughly about 0.5 in MDD, in major depressive disorder. So just above the threshold of what we consider to be effective as a medication. So these limitations really were one of the reasons why I chose to pursue neuropsychiatry, because advancing our understanding just from a receptor-based model, 5-HT1A, 5-HT2A, to more of a circuit and brain network-based model is where I can think we can advance the understanding. And we are making progress when it comes to some of the more neuromodulatory treatments like transcranial magnetic stimulation, ECT, even some of the psychedelics that are really stimulating some neuroplasticity. So I can empathize with some of the frustrations that you're also encountering when it comes to that distinction. But one piece of advice I would recommend is really trying to hone in when you're doing the neuropsychological interview. What was the chicken and what was the egg? So if it's major depressive disorder with psychosis, usually the depression will come first. And then the psychosis will only be in the context of that major depressive episode. Whereas there's schizoaffective disorder. So in schizoaffective disorder, you can have the psychosis present independently of the mood disorder. So, and even in schizophrenia, patients can also have major depressive disorder. But you want to see what's the chicken and what's the egg, what sort of comes first, because this was something that was drilled into us and ingrained into our training. It's not just for diagnostic purposes. This makes a difference when it comes to the pharmacologic treatment of your patient, because if it's major depressive disorder with psychotic features, we will use both the antidepressant and antipsychotic in the short term, but eventually the plan will be to get them just on an antidepressant. Because if you can prevent the depressive episode, now they won't actually go into psychosis. And similarly, if it's schizophrenia with major depressive disorder, then the chicken, the inciting event is the schizophrenia. So you want to maintain them on an antipsychotic. So that's where really being accurate in your HPI, ascertaining sort of the temporality of events. So you can discern, okay, what came first and what occurs in the absence of the other. So if the psychosis only is present in the mood episode, or if the mood episode is only present in the context of psychosis. So that's where you can delineate, is this mainly a psychotic spectrum illness, or is this a more mood spectrum illness?
Thank you. That was hugely impactful. It will definitely
Yeah.
help me as I go through and sort of review the HPI. And one of the things I'm noticing now, working in neurology in the past, specifically with aging populations, versus now being in a psychiatric center, is that collaborative information from family members is so important. Yeah, sometimes it feels like smoke and mirrors a little bit, especially interacting with some of the patients and trying to get their perspective on things. So I very much appreciate your help, not only describing some of the pharmacotherapies that are available now for aging populations, but with the case conceptualization that I have to do. So thank
Yeah,
you so much. I appreciate it.
absolutely. Yeah, thanks for the great question. And it's beyond even the neurodegenerative disease, collateral is just so important. You'll see it becomes evident during the interview that the patient is constantly looking towards family members, and insight can be impaired. They can often feel that their driving abilities are okay. So really getting that assessment from family members, doing a formal driving evaluation, keeping the family safe. I've had cases where patients will actually be sued because the lawyer found out that there was a diagnosis of MCI. So if they have a formal driving evaluation that can now say, no, I've been tested, I was given the green light to drive, then they have something to sort of counter that. But something always safety evaluation is just so prudent in both general psychiatric patients, but especially in patients with neurodegenerative disease.
Thank you.
We have another question in the chat that is, I think, essentially asking to give sort of a definition of what polypharmacy is. So is polypharmacy when drugs have similar mechanisms of action? Is it when drugs interact with one another? Is it both? Like, could you kind of clarify the term for us?
Yeah, absolutely. So, one of the topics we weren't able to broach because of the time constraints is enzymes. So there are many, many enzymes that your liver uses to metabolize most of these medications. So, some of the medications, like Prozac, even Wellbutrin, are strong inhibitors of enzymes that can be used like 2D6 to metabolize a lot of our psychiatric medications. So one is really doing an accurate metabolic profile to make sure you're not using a strong inhibitor of an enzyme that is metabolizing another medication that you're using. But then also, polypharmacy refers to trying to avoid using two or three medications for the same indication. So if you have one medication that's unoptimized, so if you're using, say, Prozac 10 milligrams, then you're using mirtazapine at 7.5 milligrams, then you're using, orexin antagonist for sleep. If you can pick one medication to do all three, why not? So that's how you can also avoid polypharmacy because in all three of these cases, these medications have not been increased to an effective dose. So the guidelines really say start with one medication, go to at least the max dose, and then if not effective, then try a medication from a different class. So that way you don't have a regimen of 4 to 5 different medications. And also remember, we're dealing with patients who have cognitive impairment. Do you really want them to be dealing with 20 pills during the day, on top of all of their cognitive burden? So as much as we can optimize it, minimize the pill burden, I think we can reduce that potential for interaction or them taking 2 pills versus one, them making potential errors. They are actual machines that you can recommend to the patient and family now that can dispense the medication daily. So that way you can avoid it. It can dispense the morning medications and then dispense the evening medications. So that's one. Obviously, pill boxes are there, but often if it's the patients that the one who's actually putting the medications into the pill box, the opportunity for errors are there. So making the investment, these machines can be bought for around $100 to $150, and you can load them for the month, and then they'll actually dispense the medication in a daily version.
That's really neat. I didn't even know those existed. Cool. I think maybe we have time for one more question. We had one more in the chat. I think it was on maybe your lecanemab slide, about 33% of patients on placebo advanced to CDR of 1 or 2, but then it looked like more lecanemab patients did, or I think there was just some confusion about how many lecanemab patients actually, if any, increased in their CDR sum of box score.
Yeah, so that is basically over the course of 18 months. That's how the Clarity study showed that 30% reduction. And the reduction was most significant towards the tail end. Although we see more of a reduction in the amyloid burden in the first few months and the risk for those amyloid-related imaging abnormalities is highest in the first 4 to 5 months, the cognitive benefits were a little bit delayed. So most of the cognitive benefits where we saw more of the separation between the two lines was from the 12-month to 18-month duration. And that's where our hypothesis is, although the Clarity study was just 18 months, those lines should continue to separate. And that's why we're hoping for even more, more than modest benefit for longer term amyloid therapies like the donanemab. And the good thing about the donanemab is, whereas lecanemab has to be administered every 2 weeks, donanemab is once monthly. So you don't have to worry about as frequent of administration. So quality of lifestyle wise, a little bit better.
But overall, the lecanemab was more effective in actually like decreasing CDR sum of box like over time. Like it was clearly disease.
Yeah, and we saw more of a benefit towards the tail end of the study.
Got it. Cool. All right. Any last questions before we say goodbye?
I just want to give a shout out. So next Tuesday, we are going to have a co-hosted event with the INS Dementia SIG. It's very early in the morning because our speaker or our student speaker, because it's our Reads Journal Club, is joining us from Australia. And so if you are able to, make sure you sign up and join us at 8 o'clock Eastern time, 7 o'clock Central time, very early in the Mountain and Pacific times.
Amy, there was one question that just appeared in the chat. Would you like me to address it quickly?
Sure. Yeah.
Okay.
Yeah.
Yeah. So thank you for the question. So when it comes to benzodiazepines, like we talked about, short term is the name of the game. We really want to use them as a bridge almost as the SSRI is becoming effective. And oftentimes I will receive patients who have been on benzodiazepines for 15, 20, 25 years. And that can be very challenging to gradually wean them off. You have to do a very, very slow down titration. So if we're doing everything we can to potentially get, that 5% boost from sleep, maybe 7 or 8% benefit from mood, anxiety, reducing dyscognitive medication. So collectively, it might add up to more of a robust response. So that's where really counseling the patient that we don't want to use anything that can dampen your cognition. Obviously, uncontrolled anxiety can worsen cognition and not allow them to be cognitively able. So I will, in some cases, if there's more of a panic episode, use it on an as-needed basis. But the slippery slope really becomes when you're using it day to day, because that's where the risk of tolerance and dependence just becomes so high, and they're just not as effective. It can be very challenging to take your patients off these medications.
Thanks so much, Syed. That was awesome. So helpful for us to know all of that information, because, as PhDs, we're just sort of tangential to the world of medications, but we bump up against it all the time. And I think it's just so important to that could be a very low-hanging fruit, right? If somebody is taking Benadryl nightly, it could seem very harmless, but that could be something that is impacting cognition. So, yeah, this was so great. Thank you for your time. We really, really appreciate it. And Sarah will probably post this soon-ish on.
I think it takes a couple weeks, but we'll send it out to everybody who registered.
Yeah.
Yeah, thanks for having me. It was a pleasure.
Yes,
Thank you
thank
so much.
you.
Thank you so much.
Bye, everyone.